Welcome to the Spinal Truth Show weekly Q&A edition. I am Dr. Caleb Slater, here to answer your questions. With me, I have Chris, our audio, visual, and everything in between guy, and my wife, Danielle, another expert in the field of physical therapy, specifically pelvic floor, here to read your questions. In this show, we want to answer your questions, so if you have something, if you've been troubled with a condition, symptoms that the current medical system isn't answering, isn't giving you the right treatment, isn't getting you better, leave a comment down below. You can also go to our Instagram and our TikTok pages, The Spinal Truth. You can leave a comment there. You can go to thespinaltruth.com and reach out to us. We are here to answer your questions. We are here to get you better. We are here to get you the health care that you should be getting. So let's start off. I think this week we are going to have a lot of foot-related questions. We just finished our segments on plantar fasciitis as well as Achilles tendonitis. We did a series on them on both TikTok and Instagram. So I think a lot of these questions are going to be foot-oriented. So if you're a foot person, stay tuned. All right, Danielle, what's our first question?
You got that right, Dr. Slater. Lots of foot questions. First one comes from Soccer24552. I had an MRI and it showed my plantar fascia as intact. Would a nerve issue rooting from the spine be seen on an MRI through a compressed nerve on the foot? I really appreciate your advice.
All right, so this question is asking, the patient had an MRI of her foot and the plantar fascia was intact, so there wasn't a tear, and I'm assuming there wasn't inflammation. So now she's asking if she had an MRI of her spine, would that show a compressed nerve that's affecting her foot? There's a short answer, yes, and there's a longer answer that's more accurate, as in probably not or no. And the reason is that imaging is more misleading and inaccurate than most people realize. So I talk a lot about this in my book in a few chapters, where we did a lot of studies to take people off the streets, and these people were in different decades of their life, 20s, 30s, 40s, 50s, and so on. And these people had no symptoms whatsoever. We did imaging of their joints, their ankles, their knees, their shoulders, hips, etc., and imaging of their spine. And we did x-rays and we did MRIs. And what we found that is in your 20s, you're about 30% likely to have degenerative changes. And this would mean your herniated disc, your spinal stenosis, your degenerative disc disease, your facet arthritis, arthrosis, spondylolisthesis, spondylitis, all this stuff, right? Degenerative disc disease or degenerative joint disease in your knee, labral tears, rotator cuff tears, all that stuff. In your 20s, 30% likely. By the time you hit 50, you're about 80 to 90% likely to have something. But remember, none of these people had any pain whatsoever. So what that means is, just like we show signs of aging on the outside, we show the same signs on the inside, and it doesn't necessarily correlate to your symptoms. So what happens is the medical system is strongly reliant on imaging. The doctor half the time knows what they're going to do for you, knows your condition before they've even met you, because they've read your x-ray, they've read your MRI, and this is wrong medicine in my opinion. So you go to the doctor, you say my foot hurts, they do an MRI of your foot. You say my back hurts, they do an MRI of your back. Whatever they find on the MRI that could explain your symptoms, that now gets labeled as your problem. And that's why a lot of people out there, and leave a message if this is you. You went to the doctor, you had an MRI, x-ray of your back, and it said L4, L5, L5, S1. It ended up leading to surgery. You probably had some PT, chiropractic care, you probably had some medication, injections, didn't work, maybe you even had a nerve ablation. Now you had a fusion, now you are forever changed, but your symptoms didn't go away. And why? Because there was a different level that was actually the cause of your problem, but the imaging showed L4, L5, L5, S1 as the main issue, so that's what the doctor's focused on, okay? And a lot of times these people are having hip pain, thigh pain, knee pain, and these areas are innervated by L1, L2, L3, higher up levels in your spine that and not the L4, L5 issue. So this happens a lot. I don't like to rely on imaging. Imaging is so often overused in the medical system as well. So imaging should be used if you're not getting better, if they want to rule out something nefarious like a space-occupying lesion, which would mean a tumor or a cyst or something like that, something mechanical or a growth pushing on a nerve or occupying the space. This is often not the case, and there are often other signs and symptoms that would lead you to suspect that. So more often than not, you don't need imaging right away. Maybe if you were in a car accident or a fall or there was a traumatic injury, now we want to use imaging. But this, again, isn't representative of most of the people that go to your doctor for symptoms and conditions. And if you are at home and you are watching this and you are seeing something moving around on the bottom, or if you're hearing jingling, we are also here with my new puppy, Sadie, who my wife wanted to bring along. So welcome, Sadie. You might see a little tail wag in the video. That is our new puppy, Sadie. So what you should do is ultimately, you don't need the MRI, you don't need the imaging. Go to somebody that knows how to treat your back. Unfortunately, there's not many people out there that have the right treatment, in my opinion. And see if your symptoms of your foot change. This is primarily what I do here at the Spinal Truth, is you come in with symptoms, foot, ankle, whatever. I map out your symptoms, but then I look to the area of your spine that could cause your symptoms. I address this, I mobilize you, I show you how to mobilize your own spine, strengthen your spine in a range to take pressure off a nerve, and then we see if your symptoms changed. If so, we've now proven it's a back issue, and we've done it without imaging, we've done it without injections, we've done it without medication, and we've prevented you from surgery.
Thanks, Doc. The next question is from Auntie Cab. My friend says plantar fasciitis is inflammation of the plantar fascia on the sole of the foot. It causes you to walk abnormally, thereby affecting the spine, not the other way around.
Well, and this makes me think of Waterboy, where, well, Mama's wrong again.
Mama's wrong again.
Yes, so plantar fasciitis is supposedly inflammation of the plantar fascia. However, nobody has an explanation for what led to the inflammation in the first place. We just accept the fact that inflammation is there and we need to deal with the inflammation. But what caused the inflammation of the fascia? A problem, a nerve issue in your back actually explains not only the inflammation there, but the pain, the failed healing. Additionally, it's more logical to think our body kind of works down and out. So your body works from brain to brainstem to spinal cord to spinal nerves, and those little nerves go out through your body to innervate basically everything in your body. We kind of work down and out for the most part. I'm not saying that a problem in your foot couldn't lead you to walking improperly, that could lead to then ankle, knee, hip, and ultimately back issues, but I think this is the wrong way of looking at the condition. Often it's a problem in the spine that actually led to the foot issue. Think about it too, for the most part, you're not out there walking, trudging through with a limp day in, day out. Most people have sedentary jobs nowadays anyway. So it's unlikely that the foot issue was existent for that long, causing you to walk that oddly, that now led to your spine issue. For me, it makes more sense that it was a nerve issue on the spine, a nerve issue getting to the foot. Now you have foot symptoms. Fix that, and now you fix both.
All right. Next is from Julie Stagio 2. I'm suffering from sciatica. Which medicine do you recommend?
All right, so which medicine do I recommend? So sciatica is an irritation of the sciatic nerve, leading it to be inflamed, irritated, right? The irritation comes typically from mechanical compression, all right? So it's a mechanical issue, therefore medication doesn't fix the issue for the most part, right? Medication only numbs you to your symptoms, which, look, if I'm in pain, I want to get out of pain. I don't mind taking medication, but you need to understand that it's only a temporary solution. Once that medication wears off, you will now have your symptoms again. You also have your symptoms while the medication is there, and that is actually kind of a negative because you'll do things, walk, sports, recreation, that you shouldn't be doing because of your symptoms that are irritating it more. And now that the medication wears off, now your symptoms are actually worse because you were irritating them the whole time that your body was just numb to your symptoms. So what medication do I recommend? I recommend physical therapy, surprise, surprise, from a physical therapist to take pressure off of the sciatic nerve. Some of the best physical therapists out there are ones that are certified in McKenzie physical therapy. If you go to McKenzieInstituteusa.org, you can click on local provider and find one of them. In general, I think they do some of the best job at addressing this. So ultimately, the answer is sciatica is a mechanical compression of the nerve. Medications such as anti-inflammatory steroids and injections that have anti-inflammatory steroids and pain medication in them will do nothing to fix the underlying cause. It'll just numb you to your symptoms, so you need a mechanical solution. And physical therapy and a lot of chiropractors out there can actually address this and address this well.
Great. Our next question is from Minnie05. I think I've been misdiagnosed. I've had aching feet for over 40 years. Yes, 40. I've had 4 orthotics, bought different appliances, 2 MRIs that said I had plantar fasciitis, and others that found nothing.
So to kind of recap, this is a person that's been suffering with foot pain for 40 years. They've tried the typical orthotics, probably injections. I don't remember if I heard that or not. They've probably tried physical therapy. They've tried taping. They've tried grassing. They've tried stretching. They've tried rolling. They've tried icing. They've tried resting. Assuming they've tried night splints. They've tried all of the typical approach. And why are they still suffering? Because you're getting the wrong treatment to the wrong area. You know, the definition of insanity is doing the same thing over and over again and expecting different results, right? Well, we do that in the medical system with a lot of conditions. We do the same thing over and over again, and the reason is that we get some results, so we get that little bit of support thinking that this works, and we just keep applying it to everybody that comes in with foot pain, and the overarching definition or diagnosis that gets applied to people with foot pain is plantar fasciitis. That's the box that you fit in the most, the best, most often. And again, the MRI that sometimes saw inflammation, sometimes didn't, does nothing to explain why the inflammation was there if it is there. And often it's a compression of the nerve, causing the nerve not to supply the tissue, causing the tissue to not get as much blood flow. Now the tissue won't operate as properly around it, the muscles, tendons. It'll lead to decreased blood flow. It'll lead to fibrosis. It'll lead to inflammation as well. And this can all be solved by addressing it at the spine. So again, I would suggest, and this is going to be the overarching theme of this segment, which could easily be called It's Your Spine. Which was supposed to be the title of my book, but it ended up being The Spinal Truth. It's so often your spine that this is the approach that I've had to take when people come in with basically any symptom. And what we do is we map out your symptoms, and then we look to your spine to see if it's not just attributing to, but the actual cause of your symptoms of your condition. And it's been so often the case that I wrote the book. I'm here trying to give this information out because I think in general our medical system operates in tunnel vision. We become so over specialized that if you go to the shoulder guy is going to look at the shoulder. If you go to the knee guy is going to look at the knee. If you go to your podiatrist is going to look at your foot. But they don't look at your body as a whole. They don't view your body as a whole and think about not just the symptoms, but the cause of your symptoms, not just managing your symptoms with medication injection, but curing the underlying cause. So for a lot of people out there, they have this story of this person. It's long-term chronic pain that is getting the same treatment options as everybody else. The orthotics, injections, possibly even surgery for like a fasciotomy or plantar release. Physical therapy that's mainly stretching and rolling and doing little marble pickups with your toes. And why is it not working? It's because we're just looking at the problem through a small tunnel, a small lens. And this is the information I'm trying to get out there. There's a different way. If you're getting treatment to an area and it's not working, and working within a relatively short period of time, for most things you should see somewhere around 50% improvement or more within about 4 to 5 weeks. So if you're not seeing that, then you're probably getting the wrong treatment to the wrong area. If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system, and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
All right. Next we have from A73. I don't have pain in the morning, only after 30 minutes of standing and walking. It's in my right leg and in the right side of my heel. I've tried everything. What is it?
Okay. So, And again, we just finished our segment on plantar fasciitis. So this person's saying they don't have pain in the morning, which would be your telltale plantar fasciitis, right? Supposedly your plantar fascia heals down those micro tears overnight, and this is the common way of looking at this. And then when you wake up, it tears, and that's that glass, stepping on glass, breaking, tearing feeling in the first few steps in the morning. But this person's saying they don't have it, right? It's only after 30 minutes of standing, and they're saying in their leg and their heel. And there can be a few things that can cause this. I would need to know a little bit more information. This person could have a stress fracture that's responding to increased stress, and when you're not putting pressure through it, it doesn't hurt. When you put pressure through it, now it hurts. That would typically be presented with increased activity. They increase their training. They're doing a lot of hiking. Maybe they did have some form of injury. But another thing that could explain this is a problem at the L4 segment of your spine. The L4 segment innervates the outside of your leg. So he said leg. Leg can kind of mean anything, but lower leg would be this outer area right here. That's your L4, which would also go a little bit into your foot, into your heel. So you're standing up, you're putting pressure on your spine, and now you're getting these symptoms. And I'm assuming when this person lays down, those symptoms also go away. So I would need a little bit more information to give a little bit better of an answer. But again, one explanation could be a problem in the spine that is causing your symptoms specifically in the L4 area. Again, some of the best physical therapists out there are McKenzie physical therapists. I don't agree with them completely. I actually think they get a few things wrong, but in general, they do a pretty good job of mapping out your symptoms like I do and then looking to your spine to see if there's a cause. You can go to the McKenzie Institute USA.org. You can go to the spinaltruth.com if you'd like an appointment with me. Typically within one session, I'm able to give you a pretty good plan on what I think is going on, how I think you're going to heal over the next few weeks, and with what game plan that's geared towards you, as well as I try to show improvements right there on the first visit. And I think that's something that most people don't do. I try to see improvements in strength, range of motion, and or pain on the first visit.
Great. Our next question is from Jack. Hi, I'm wondering about sleep apnea. Is there any treatment for it? Thanks so much.
Yeah, and again, this segment is the spinal truth. It's your spine. So one of the answers is going to be spine, definitely. So most of the people that are coming to me, they've done the typical approach. So for sleep apnea, it can be anything from a closed airway, excess tissue in the mouth and back of the throat. It can be due to drinking. It can be due to some medication changes. It can be due to obesity. Most of the time, these people have gone the traditional approach where they've tried the mouth guards, they've tried some of the CPAPs, they've tried some of the medication, and they're not getting the relief, the changes that the doctor would expect. Why is that? Well, an explanation would be that they're still not treating the right area, and your spine literally innervates everything in your body, which includes your lungs, it includes your breathing. C3, C4, C5 in your neck innervates your diaphragm. So there's a saying, C3, C4, C5 keeps me alive. Additionally, your breathing ability is modulated by your sympathetic and parasympathetic nervous system, and your ability for your lungs to expand and contract are due to your muscular system as well as your spine. So a lot of times people are actually rigid and stuck in their thoracic spine. They're not able to open their chest. They're not able to breathe as well, and this could lead to sleep apnea. There's a chapter in my book, a patient who was wrongly diagnosed with asthma, and he went through all the normal routes. He was having difficulty breathing. He went to his doctor. He ended up going to the emergency room because of difficulty breathing and some anxiety coming from that, specifically when he was trying to go to sleep. He went to a pulmonologist, still not getting any answers. It kept getting labeled as your run-of-the-mill asthma or exercise-induced asthma. He tried medication. He tried different breathing techniques. Nothing's working. Came to me. I looked to his spine. An area of his spine that could explain his symptoms was stiff, tender, and I worked on it. I showed him how to work on it, and within that session, he was breathing better. He felt better. Within a few weeks, he was 100%. And again, it's just something that nobody looks at. I guarantee you how many people out there that said that they had asthma, breathing issues, or sleep apnea, went to their doctor, and the doctor said, hey, it might be your spine. Let's get your spine properly screened, which doesn't mean imaging. Let's get your spine properly screened, and let's see if that could be the issue before we put you on medication, before we give you a CPAP. So absolutely, the levels of your spine would be somewhere around T6 and up, so maybe C3 to about T6, so about this level of your spine, somewhere around there. Typically, they respond pretty well to extension exercises to take pressure off those nerves. But yeah, absolutely, your spine can cause sleep apnea, sleep changes, sleep disturbances.
So interesting. Next, we come back to Aunt T-Cab again for a question about your videos have procedures on the calf, not the plantar fascia.
Yeah, so again, we just finished our plantar fascia series. So for next week, people, please ask some questions outside of the foot. Happy to talk about it, but I don't want to be the foot guy. Let's get some other questions in here. This came off of a series that got a lot of views, around 170,000 views within the first week, about what to stop doing, and that would be rolling your calves, stretching your calves. That would be Graston to your calves or Graston to the bottom of your foot, taping your foot, sleeping with a night splint, injections, medication for a diagnosis of foot pain or plantar fasciitis. Your plantar fascia is actually one continuous, everything's related in your body, right? Everything's connected, and that's very true for the fascia in your calf that turns into your plantar fascia of your foot. So a lot of the treatments out there, why are they aimed outside of your foot to treat your plantar fasciitis? And that's because the plantar fascia actually comes from above in your calf. So stretching your calf, stretching that fascia actually stretches out in tandem the fascia of your feet. That being said, the point of the video was to not do that, was to not stretch your calf, not stretch your foot, not work on the fascia of your foot, not work on the fascia of your calf. It's typically not this. And if it is, if it's a tight calf issue, stretching your calves works very well. If it's a fascia issue, specifically inflammation, resting, ice, compression, anti-inflammatories work pretty well, right? If it's an inflammatory issue, taking anti-inflammatories, resting it works well. Most of the time though, it doesn't work for you. And why? Because the inflammation was a symptom of something else. Also too, when you walk, and this is the point in the video, when you walk, you naturally stretch out your calves as well as your plantar fascia. When you walk, you bend your foot backwards with every step. You are constantly stretching that out. So it's actually typically overstretched. Additionally, stretching it, a lot of times stretching it like this, you're, yes, stretching your calf fascia as well as your plantar fascia, but you're also pulling on your sciatic nerve, and that sciatic nerve is what innervates this area. Nerves don't like to be pulled on. Nerves get pissed off when you pull on them. It's, if you watch football, a burner or a stinger is a forceful separation of the head and shoulders. It pulls on the brachial plexus, which is the network of nerves. This pisses those nerves off, resulting in temporary tingling, pain, numbness, weakness, and even paralysis, right? That's short-lived because it's just a quick stretch, the nerves got irritated, they heal pretty quickly, but when you do this over and over and over again, you're constantly irritating that sciatic nerve. It might even feel good in the moment, but what happens is you kind of deaden that signal and you get lulled into false sense of improvement because you've deadened that signal. You feel better, but then eventually that signal is going to wake back up, and as it's waking back up, you think your symptoms are returning, but it's actually improving because you've stopped pulling on that nerve. So yes, the videos show working on the calf. The point of it was don't do that. Don't work on the foot. Look to the back. Don't stretch your already overstretched calf, already overstretched fascia. It will just irritate it and it won't work. If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
Our next question, to switch gears, is from Bayou Leverett. Could you share some information on knee tendonitis? I have some severe issues with it and really need some help.
Yeah, so knee tendonitis. All right, so this is typically labeled as jumper's knee. Normally it's a tendonitis of the quad or patella tendon, just labeled based off of where it is in the knee. It's one continuous tendon. This tends to happen after an increase in activity. You started playing basketball again, you went back to running, and you amped up your running more than usual, something like that. If it is tendonitis, rest, ice, anti-inflammatories, and gradual return back to activity typically works. Some gentle stretching, some gentle strengthening. Most of the time though, it's actually labeled, it should be more properly labeled as tendinosis or tendinopathy. And what this is it's actually a degradation of the tendon. The tendons become thickened, calcified. It's actually have less blood flow in the area. It forms little blood bundles called neovascularization. And that's actually what causes a lot of the pain in the tendon. The reason this is important in changing the labels is because the treatment changes too. Instead of treating it with rest, ice, anti-inflammatories, you actually want to load that tendon. You want to break up that calcification. So progressive loading of that tendon through its range with increased resistance is typically key. If you want to see an example of this in the recent video that I did, the recent video series I did for Achilles tendonitis, tendinosis, tendinopathy, I show progressive loading of the gastroc Achilles area, and this is something similar that you'd want to do at the knee. However, this is also called the spinal truth show, right? So we need to also bring this back to the spine. So often the case, the cause of your knee pain isn't actually the tendon, isn't actually the meniscus. It's actually a problem in your spine, specifically your L2, L3, L4 area of your spine. This area gets stuck in extension. So people that run a lot, people that bend backwards a lot. So like your gymnasts, like your cheerleaders, like your football linemen, sprinters specifically, their back gets stuck in extension. Women who have just been pregnant for 6 months stuck into extension. And then once they've delivered, they don't know to get out of that position. They don't have the ability. Their abdominals are weak. Their lumbar spine is stiff. The compression on this nerve causes all those same symptoms and gets misdiagnosed. So if you want an example, if you want to see if this is the case for you, you can go to my plantar fasciitis video. Through this series, at the end of the series, I show 2 exercises to do. Exercise number 1 would be for somebody that's stuck in flexion. For exercise number 2 would be somebody that's stuck in extension, and this is often the case for people with knee pain. So again, this is a different approach, a different viewpoint, and that's why I'm here, because I do have a different viewpoint than the medical system as a whole. When you come in with your knee pain, with your jumper's knee or your patella tendonitis, we would map out your symptoms, we'd watch you jump, maybe we'd watch you run, we'd see you squat or split squat, and we would see how much pain you have in what range, but then we would look at your back and see if that area that could explain your symptoms, again, your L2, L3, L4, was stiff, tender. We'd mobilize it, show you how to mobilize it, and then we'd re-look at your symptoms and see if they changed. If they did, we proved right then and there that at least some of your symptoms are attributed to from your spine, if not caused by your spine, by compression on that nerve entirely.
Thanks for that great explanation about knee tendonitis. That leads us into our next.
And I hope this stays in this video, but you're reading it like you're a helicopter traffic news report, right? Like, thanks, Ollie.
Well, you want it to be exciting or boring? All right. So our next one is a comment from Dr. Nick PT. I opt to use the terms reactive tendinopathy and degenerative tendinopathy with patient, as it conveys a better message of the issues and more to date than the classic itis and osis. Your thoughts?
Yeah, so I get this from a lot of the PTs and other people in the medical professional for these videos. The videos that I'm doing on Instagram and TikTok, they're geared at the general population, and so is my book, right? Like I want to inform the general public, and using these overly esoteric labels that are just germane to our level of education in this field isolate a lot of people, right? Additionally, it's a label. Right? Ultimately, you want to argue over a ticky-tacky labels, which there is some importance to, but they continue to evolve and change almost for no reason as well, right? The difference between degenerative tendinopathy and tendinosis is basically nothing, right? Most of the time when you're talking to a patient, you're not going to be able to say reactive tendinopathy and degenerative tendinopathy versus tendinitis and tendinosis. You're going to have to put it into patient terms that they understand. Additionally, too, I see the label tendinitis applied almost all the time in the medical field, specifically by doctors, right? And I think because they're using the more ease term, not necessarily the one that best describes their symptoms. So, and this becomes dangerous too, right? So they want to apply the term that's most widely known so that everybody understands it, but it does change sometimes the way the treatment is. So tendinitis and tendinosis, types of tendinopathy, are treated differently. So yes, labels matter, but the treatment matters more. And you should know based off of symptoms, how long they've been there, the way the patient's presenting, you should know which one's which. And again, we change these labels all the time. CRPS right now, chronic regional pain syndrome, used to be RSD, reflex sympathetic dystrophy. We've changed in the vestibular world. Instead of canalith, it's canalith repositioning maneuver versus the Dix-Hallpike procedure. Sometimes we just change these, I think, just because, just to be annoying.
Yeah, and I'm embarrassed that 16 years PT, I would never have known to talk to a patient about reactive tendinopathy.
But you also wouldn't, because they wouldn't know what that means either. So you have to fight the, yes, we're evolving in our understanding, but we also have to distill this information to the person that's trying to understand it from a base level, right? And so for me, I am an idiot when it comes to computers. So if I start talking to somebody about computers and they're using language that's only understood in their field, or honestly, if they're using anything above the basic language, I'm not going to understand it, and I'm probably going to space out. And I might not be able to use their services because I don't trust what they're saying. So I fight in these videos putting it in terms that support my credentials and my education level, but also trying to get the information out there. So you can pick which side you want to be on. I'm going to put the side where most people are going to be able to understand it. But if you want to have a clinical conversation with me, please message me. I'm happy to answer questions. If I know you are a fellow PT or if you're in the medical field, I'm happy to talk with that verbiage as well.
Wonderful. Do we have time for one more question?
Oh, we do.
So exciting. All right, now we have one from Beth. I have scoliosis and constantly have one leg going shorter than the other, which my chiro fixes every 3 weeks. I tore my plantar fascia 4 months ago and I have constant pain now. Nothing helps.
All right, so a lot to unpack in this. So one thing that I'd like to address is if your chiro fixes it every 3 weeks, your chiro doesn't fix it at all, right? If you have to keep going back for the same issue, it's not fixed, it's just pacified, right? And this is kind of the majority of our medical system, is they apply pills, injections, we crack your back, you feel better in the moment, we massage you, we stretch you, you feel better in the moment, but then a few days, a few hours go by and you're right back to where you were. You aren't better, you were just pacified. You were just numb to your symptoms, you were treated, but you weren't cured. So a lot of times, and not to throw shade at the chiropractors, but you notice a lot of people that they say, oh, I've been going to that chiropractor for 7 years, for 10 years, for 15 years. If you've been coming to me for 15 years, I failed, right? So if you have to go back for treatment over and over and over again, you're getting the wrong treatment. Yeah, it might make you feel good in the moment, and there's nothing wrong with that, but don't misunderstand it as a cure. So I also don't like to look at terms of leg length discrepancy. This is kind of, again, more chiropractic speak, where your body's out of alignment, and I don't like to look at it like that because I don't think that's the case. Our bodies are full of asymmetries in the first place. You can have scoliosis and you can have no symptoms whatsoever. You can not have scoliosis and have symptoms coming from your spine. Certain times, certain amounts of scoliosis, scoliotic changes, yes, they are going to lead to symptoms, shortening of one side, lengthening of another, compression on one side, stretching of another. But in general, most of the time, people that go to a chiropractor will be labeled with scoliosis, maladjustment or malalignment, as well as some form of leg length discrepancy. I don't like to look at symptoms in those in that lens. I'd rather look at your symptoms, hear your symptoms, how they behave, where they are, and then look to the area of your spine that could explain them. Not necessarily get ticky-tacky in which leg's longer or shorter, is your ilium nutated or counter-nutated or upslipped, and you can get into a lot of these PTs as well, that they look at all these small little things that the outside observer can't really see, so they can't really argue with, and I think that's where the sales aspect comes in. You see this a lot in myofascial work, you see this a lot in craniosacral, and it's stuff that my wife and I, we've tried to learn in the past, but we haven't seen it be applicable to patients. So this person said they tore their plantar fascia and it's painful all the time. After a few weeks, if it's still painful, it's probably not coming from that tear. That tear, and I don't know, I don't know this person at all, I haven't talked to them, but that tear could have just been there. It could have been a chronic tear that happened a long time ago, and it's getting wrongly explained as the cause of your symptoms. Tears also too, in general, if you're not putting pressure on them, if you're not stretching them, they don't typically hurt in that moment. So if they're in a shortened position, which would be you laying down with your foot plantar flexed, now that fascia, now those muscles, tendons, everything is shortened, so you're not putting any stress on the tear. It shouldn't hurt specifically after a few weeks. So if that's the case, if you're at rest, it's hurting. If you get any numbness and tingling, then it's absolutely not from the plantar fascia, right? And I explain this in my book, The Spinal Truth. In basically every chapter, I start out with some of the signs and symptoms that mean nerve and not a local issue like muscle, tendon, fascia, ligament, joint, right? One of them is if you have pain at rest. So this person's kind of alluding to that. One of them, if your pain isn't changing after a period of treatment, so maybe 4 to 6 weeks of treatment. Another one is if you get numbness and tingling, then it almost has to be a nerve issue. And another one if it's bilateral. So if you have any of that, this person out there that's reaching out, if you have any of that, then it's probably not coming from your plantar fascia. And if you have to keep getting your hips put back into alignment, then you're not getting the treatment that is ultimately going to keep you better.
Well said. Thanks for that great segment this week.
You're welcome.
Dr. Slater.
I hope that the people that asked the questions, I hope that that was helpful. I hope for you, the viewer, that that was informative. I'm sure that we're going to get some feedback that this isn't what you would do, this isn't what you were told, and that's the whole point. The whole point is that I see something different, something that I've seen so much more effective than any other treatment that I've tried in my 16-year career. And I think it should be much wider known and applied to patients, especially before your medications, injections, and surgeries that all have their side effects and negative outcomes and might not address the underlying cause. So if you're out there, if you've been suffering with pain, other symptoms, dizziness, nausea, if you want a better way, if you want a different way to view your symptoms, thespinaltruth.com. You can also look for my book. I give you a lot of information. Each chapter has a different body part or diagnosis that has an actual case that talks about how I would treat it, what the patient came in with. If you read the book and you'll read the chapter that's pertaining to you, it should sound like the journey that you've gone through. I also have chapters in there about the healthcare system as a whole and how I think it's letting us down. But anyway, if you have questions for next week, you can reach out to us on TikTok and Instagram. You can leave a comment below. We're here to answer your questions. We're here to show you a different way. We're here to make changes in healthcare.